This is when you have an intimal tear and then blood dissects between the intima and the media, creating a false lumen. This most commonly happens in middle-aged men, people with hypertension or connective tissue disorders like Marfan's or Ehlers-Danlos, or people with bicuspid aortic valves. So shear stress from uncontrolled hypertension or connective tissue weakness leads to this intimal tear, and this allows high pressure flow into the media, separating the layers. These patients will present with sudden, severe tearing, chest or back pain. It'll often be migratory. They might have pulse deficits, neurologic deficits. They might present after a syncopal episode or even in shock. How do you diagnose this? On chest X-ray, you might see a widened mediastinum, but the gold standard is a CT angiography of the chest and the abdomen. You might want to consider a TEE for unstable patients. Type A involves the ascending aorta, and this is a surgical emergency. Type B is the descending aorta only. Usually this is medically managed. You'll want to start with medical management as a bridge to your TVAR, and so you'll want to start with IV beta blockers, usually esmolol and labetalol, for a goal heart rate less than 60, and these are easily titratable and quickly reversible. Step 2, you'll want to add a vasodilator like nicardipine or nitroprusside if the systolic blood pressure is greater than 120 despite beta blockade. These medications are the same medications you would use in the type B when you have the descending aorta involved and no rupture or ischemia. But if it's complicated like malperfusion, there's a rupture, there's uncontrolled pain or hypertension, then you would still go to the TVAR.